we're so excited. We're back in person, well, sort of hybrid. We have 200 people registered online, so we're going to do this hybrid for the first time. Last 2 years were fully online, and then the first 2 years when we were doing it for the first time, we were in this room. So we would like to get started. We have an opening remarks by our dean, Dr. Shri Zahir. And David, if you could please play Shri's video message to us.
Good morning.
Get us started.
My name is Shri Zahir, and I'm Dean of the Carlson School of Management. Thank you all for joining us for the 5th annual Convene conference. This is the first ever hybrid event. Welcome to those of you who are joining us in person at the Carlson School, and also to those who are attending virtually from around the world. This annual conference is hosted by the Business Advancement Center for Health, or BACH. BACH launched in January of 2022 with the vision to create a healthcare system that delivers equitable care to all individuals. They do that by designing business-driven innovations that address gaps in health equity, and by convening conversations like this to improve value in healthcare through academic, industry, and community partners. BACH evolved out of Carlson School's research and outreach efforts in the health sector, including the award-winning COVID-19 hospitalization tracking project led by BACH's founding director, Professor Pinar Karacha Mandik, who is now a distinguished McKnight University professor. Pinar is also leading a research grant to reimagine healthcare funding through the creation and development of a financial tool called a social bond. BACH continues to show us how to use business as a force for good to make healthcare equitable and accessible for all. You will hear today from an excellent lineup of speakers throughout the program who will explore how data, analytics, and technology can help to identify gaps and drive solutions to advance value and health equity. A big thank you to our speakers, moderators, and our conference sponsors, and for the entire BACH team for making this year's conference possible, and for the contributions all of you will make to improve accessibility, affordability, and equity in the healthcare system. Now, it's my great pleasure to welcome Professor of Finance, Pinar Karacha Mandik, the founding director of BACH.
Well, thank you, Shri. Thank you. Thank you so much. Thank you so much. It's so humbling to be in a space like this with all of you. And before we get started, I do want to read a land acknowledgement. We acknowledge that the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. It is important to acknowledge the peoples on whose land we live and work and learn as we seek to improve and strengthen our relations with our tribal nations. We also acknowledge that words are not enough. We must ensure that our institution provides support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. Thank you. As Dean Zahir mentioned, the Business Advancement Center for Health, BACH, grew from the healthcare research and outreach that we have at the Carlson School. And we are committed as a team, as faculty, staff, our students, to innovate and reimagine challenging problems and their solutions with a mission to improve value and equity in health. We know we can't do that alone as an academic institution. And we know we can't do this alone as a business school. We need all of you here to achieve that mission as a community. And this is why we're here today. We need to all courageously dive into those intersections of different fields, different stakeholders, and translate for each other, and so we can understand the problems and create solutions. One key aspect of this intersectionality I'm referring to in healthcare is the collaboration between different fields, including business, public health, medicine, engineering, many other fields, public health. These fields bring very unique perspectives to the table, and when they collaborate, beautiful things happen. We see it all the time. And another way to think about intersectionality and what it emphasizes is the importance of various stakeholders. When we speak about healthcare, we're talking about healthcare providers, payers, technology companies, policymakers, again, many, many different types of stakeholders. And by only including such diverse perspectives into the way we think about the problems and the solutions, that we can create inclusive, equitable, and effective solutions. Also, we need to train our students in these intersectionalities, and we're very, very committed to do that. Just very recently, BACH hosted, in collaboration with many other schools and faculty and staff representing different colleges and schools, we hosted the University of Minnesota's Interdisciplinary Health Data Competition in partnership with Minnesota Community Measurement. And we had this year 74 students who competed in 22 interdisciplinary teams, and they represented 14 different colleges and schools. And we are so proud of that work. A lot of really interesting projects came out of that. Now, we're here for the 5th annual Convene conference, Data, Technology, and Connectedness to Health. And our moderator, Dr. Arkel Giorgio, whom I will introduce in a minute, will tell you a little bit about how we landed on this topic and the theme. But just a few cents on that. We know that in this rapidly evolving healthcare landscape, the pursuit of health equity has taken center stage. It is a fundamental principle. And we view data, technology, and connectedness. They're emerging as solutions, tools for us to think about, again, how can we create solutions to address this fundamental principle. I want to thank all of you here. You are here. We are honored to have each and every one of you here. Your presence here at this early day shows your commitment to this kind of a mission on equity in healthcare and how we can think about, imagine ways through data, technology, policy. You'll hear from our speakers many different ways that we can approach these problems. I want to thank our speakers. We have a really, really exciting, engaging group of leaders who will share their expertise and their insights with you. I want to thank our sponsors. Without them, an event like this wouldn't be possible. Our presenting sponsor is United Health Foundation, and our gold sponsor is University of Minnesota's Office of Vice President of Research, Research Computing Group. And the fact that we're here, we can do this in person, and it takes a lot of work and effort. I want to thank our conference steering committee. We have Dr. Arkel Giorgio, who is an executive in residence with the Carlson School. BAC's program manager, Dr. Ed Walchuk. He's maybe, there he is. We have a fantastic program management team, Kim Choik and Becky Strello. Maybe they are outside. There is Becky. And we have MBA student members, Nida Yamin, Kalyan Frike, and June Chen. All right. Now, I would like to introduce Dr. Arkel Giorgio, an advisor, a speaker, an educator, a journalist, and a physician. And Arkel and I have gotten to know each other through her role as an executive in residence at the Carlson School of Management for many, many years now. Dr. Arkel Giorgio is also the chair of the Board of Children's Minnesota. She's a fearless healthcare advocate, and she has this book that I go to as a health economist myself, Healthcare Choices, 5 Steps to Getting the Medical Care You Want and Need. Fearless advocate for healthcare consumers, and years of executive experience, including serving as chief medical officer at United Health, as well as most recently, chief health officer at Starkey Hearing Technologies, and currently leading the Giorgio Consulting. And you will probably have seen Arkel on TV a lot because she's a regular at KSTP. And lots of awards. I can't count Arkel's awards. Some of them include the Women in Business Award by the Minneapolis-St. Paul Business Journal in 2021, and the Women's Health Leadership Trust Forum Award for her exceptional efforts to transform healthcare industry in 2022. She's a wonderful colleague and collaborator and founder of one of our other signature projects, which I'm so thankful we were able to sunset, the COVID-19 hospitalization tracking project. She was on the table that weekend when we decided we were going to put all hands on deck and get this project started because it was so needed. That was March of 2020. and the project took 2.5 years. Arkel, thank you so much.
Thank you, Pinar. Are we on? Can you hear me in the back? Awesome. Pinar, you broke your promise to me, which is that you were going to shorten that bio, but I really greatly appreciate it. Thank you very much. Welcome to all of you. This is our 5th annual Convene conference, and I am so proud to have been involved with this conference since the very, very beginning. So I want to welcome all of you, of course, all of our speakers, all of our sponsors. Thank you so much. And I want to highlight that United Health Group Foundation, actually I went to an event earlier this week at Evereve in Edina and got this beautiful bracelet, this stone bracelet from the foundation that symbolizes our desire for hope. And I just thought it would be appropriate to wear today because that's what we all want from this healthcare system is hope. We want that and we deserve that. So thank you so much to our presenting sponsors and all of our sponsors. The quality and the content of this conference has continued to evolve and improve year after year. And so I thought I would just, for those of you who might be a little less familiar, remind you of the themes that this conference has addressed in its prior year. So in 2018, our inaugural year, it was the intersection of medical industry and data science. We were just getting started. In 2019, it was on the ROI of artificial intelligence. I'm still not sure that we have figured the ROI out. In 2021, it was using data science to address gaps in mental health, SDOH, and health equity. In 2022, it was consumerism of healthcare and digital health. And this year, of course, it's data, technology, and connectedness to health. And I thought it might be a little bit interesting to share with you what inspired this theme this year. Of course, conferences like this take months in the planning, lots of brainstorming before anything ever crystallizes, and lots of breakfasts and lunches with Pinar and the team that put it together. But one of the inspirations for this theme this year is that I don't know how many of you know that the United States is bidding to host a World's Fair in 2027. Who knows that in the room? Have you seen anything about it? Oh, the United States has not done a very good job of advertising the fact that we're sort of a stealth bidder, right? So Malaga, Spain is all over the place with their king just making a big deal over their bid to host in the same year. So that's who we're really bidding against, is Malaga, Spain. Our State Department is being a little quieter about it. Nevertheless, if we win this bid, and we will know on June 21st whether or not the United States is hosting this World's Fair in 2027, the host city will be Minneapolis, Minnesota. Is that just the coolest? And it's even cooler because the theme of the World's Fair that we would host is healthy people, healthy planet. Health and well-being for all. I have been privileged to be part of the board and the bid committee for this event, and I've also had the opportunity to work with our own University of Minnesota, Dr. Jacob Tolar, who's Dean of the Medical School, to put together how we imagine this fair would play out if indeed it comes to our beautiful city. And I pulled on many of you, including Pinar, to give us ideas about what would it look like? What would it feel like? What would the pavilions look like if we actually had the chance to host this World's Fair? It was really fun to imagine what healthcare might look like in 2027 and what the challenges and opportunities would be. So when we put this together, there were 4 main areas that we pitched to the organization that makes the decision about who gets to host. And one is digital, diagnostic, and therapeutic advancements. There would be pavilions and exhibits on how these technologies, how we screen for, diagnose, and treat disease. But also, we would focus on how digital health can improve the world's ability to more equitably allocate access to medical and public health resources, because a World's Fair is an opportunity to start a global conversation. Another pavilion would be on lifestyle, diet, community norms, behaviors that drive health and longevity. And not only what do we know about health and longevity, but what can we learn from other countries and what can countries learn from each other. The third is that we have to demonstrate and show how we are dependent and rely on a healthy planet if we want healthy people and communities. And fourth is that we want to advance global connectedness and compassion and respect and support for our own wellness and mental well-being. So these are the conversations that are partly what inspired this theme in connectedness, because it's not any one of technology or lifestyle or environment or the human spirit that we need. We need all of these things, and we need all of them to work together in concert in order for us to achieve our best human state. So, because at the end of the day, the desire for good health is global, health care is local, and care is personal. And it's a challenge to bring all of those together, but as we convene in forums like this, that's what we hope to accomplish. So I am so excited about this theme, and others are too, because I can tell you that before this conference even starts, or before it even started at about 9:05, it's already won an award. Because at 10 a.m. today, it will officially be announced that this Convene conference is a Bronze Stevie Award winner in the 21st Annual American Business Awards in the conference and meetings category. So you are already in an award-winning conference. So congratulations to the team that put that together. So let's jump right in. I want to introduce our keynote speaker, Peter Quimby. I didn't know Peter until just a few months ago. I was introduced to him by a friend. We met in a coffee shop in St. Paul, and he knocked my socks off. His story, professionally and personally, was so compelling that over coffee, I probably overstepped a little bit of a boundary and said, I think you should be the keynote speaker at Convene, and I was hoping that Pinar would agree with me, and ultimately she did, because he knocked her socks off too. I'm not going to go through a lot of his bio, and I'm not going to go through a lot of bios at all in this day, because you can read them, and I would encourage you to do so, but I'll give you some highlights that were really particularly interesting to me. He's a healthcare sales and operations executive, and until recently, he was the North American sales director for Google Cloud's enterprise AI business for large Fortune 100 companies. He also has Microsoft and Dell in his pedigree. He graduated from West Point with a major in systems engineering. He served in the 82nd Airborne Division at Fort Bragg, North Carolina, one of the highest honors that you can have and places that you can serve. And he got his MBA from the Carlson School of Management and Marketing. Isn't that awesome? He's an avid outdoorsman. He enjoys running, scuba diving, skiing, and enjoys playing electric guitar. And Peter, what I learned about you, because I will give myself credit for being a really good Google stalker. All of you will find that out. Other speakers will find that out today too. That he is a huge Eddie Van Halen fan. So, okay. And by 2012, he had seen him 8 times. Peter has a joie de vivre that's just more magnificent than I've ever experienced, and for good reason. He'll share that with you in his keynote as he talks about the intersectionality that data provides as a value. Let's welcome Peter Quimby.
You'll find that pocket. Okay, can you hear me? Well, thank you, Arkel. Thank you, BACH, Pinar, everybody, for having me. Lucky for you, Arkel just made my presentation about half the length it was, because she went through a lot of my content, but my background. All joking aside, thank you very much. It's really exciting to be here. It's very different being on this side. It's been 18 years since I was a student sitting on the other side. I think I had my first welcome class here. I think I did financial management in this room. And so it's really exciting to be here and have an opportunity to talk to you today. We're gonna spend a little bit of time talking about healthcare and value creation. And I'm gonna do my best to provide maybe a different perspective. I don't know that we've yet answered the question on the value of AI, but I'm working really hard to solve for that, and we'll maybe talk a little bit about that too. Did I get to go forward? There we go. Perfect. Okay, so jumping right into it here. Here's a picture of me a long time ago. As Arkell mentioned, I was most recently at Google Cloud. I spent a little bit of time at Microsoft and Dell. I've been in high tech for the past 15 years, and it's been really very exciting to me. I actually started that when I was at Perot Systems. I got recruited by a West Point graduate who was looking for somebody. Actually found me on Monster. If some of you are old enough to remember Monster, saw my resume, pulled me in, and I started the journey of learning what healthcare was, what data was, and it's important, I think, really to talk about. I haven't just been in healthcare. I've been in consumer product goods. I've been in retail. I've been in a lot of different industries. But for the past 15 years, I've predominantly been in healthcare. I've called on and served and been in sales meetings with senior executives at CVS, CVS Caremark, Mayo, HCA, Cardinal, Anthem, and most recently, when I was at Google, I led the Medtronic relationship globally. So it's interesting when you sit from a payer, from a provider, when you're in specialty pharma, you sit and you see a lot of really interesting conversations, heady conversations, challenging conversations. And so I thought it would be interesting to start this. Actually, I'm gonna pause here. You might be wondering why there's a green egg on the grill here. As I was prepping for this and I was reviewing with our 12-year-old daughter, I was talking about how I was gonna just make an allusion to what's really important to her is the fact that I'm really good at making some Brussels sprouts and steak on the green egg. And she said, what you really need to say is you have an awesome 12-and-a-half-year-old daughter. And so that's really what I wanted to talk about here. And so I just want to acknowledge my fiance, her daughter there. So she's really amazing. So I thought I would start by sharing some, what I hope is something really provocative. You might recognize John F. Kennedy on here. This is him when he delivered the Man on the Moon speech, which was delivered to Rice University in 1962. And if you read through this quote, you might not remember it as the Man on the Moon speech, but in the middle of it, he talked about the challenges and the vision that he was laying out for the next 10 years. And he talked about it and he said, we have to do these things because they're hard, not because they're easy. And that's a really, really powerful statement to me. And I think it should resonate with a lot of you. We all work in healthcare to some degree or another, and what we do is hard. It's really hard. And I've sat with a lot of senior executives in the room where we're making the decisions, and I repeatedly hear how hard it is. So I thought maybe I would start with this and sharing with you, playing back some of the things that I've heard you say and where there's real struggle and concern, because of that is born opportunity. So the first thing I hear a lot of is the healthcare system is very reactive. Depends upon the patient going to a doctor and starting the process. And the number of times I've listened to a CEO or a CMO or even a doctor frankly say, you should have come in sooner, I didn't know we were behind, or where is our inventory, or we're just chasing the next thing. It's incredibly reactive, and because of that, it's sometimes slow to respond, sometimes it's too late to respond. The second thing that I think is it's risk avoidant. I've heard this and I've personally observed it. I would go so far as to say it's very fear-based. We're not willing to go, we can't. There's too many laws, there's too many rules. What will happen? I'm afraid of this. I can't answer to this. I'm not gonna be able to explain this. What would happen? And so consequently, we find ourselves making evolutionary sort of progress in things and not revolutionary progress, because we're really kind of stuck in that fear-based space. The third thing, and I think that this should resonate with everybody as well, is there's a lot of waste and inefficiency in the process. Unnecessary procedures, invasive procedures, unnecessary delays getting from A to B, the inability to get an approval from here, the inability to get a drug authorized, the inability to get a procedure authorized. It's challenging, it's unnecessary, and I think it has to impact the quality of health that people receive. The fourth thing, I guess, is this is one thing that I see leaders get really excited about, and I personally have a passion around. Consumerism is real. It's a real opportunity in the healthcare space. Personal devices, phones, watches, devices at your house, the ability to search the internet, Dr. Google, Apple Health, all of those things are putting a ton of information in patients' hands, and it's driving patients to make different choices about their healthcare, and it's something that I'm seeing leaders consider more and more thoughtfully as they make decisions about where do they spend their money and where do they invest in their business. And the last thing, and I'm sure that this will resonate with everybody, there's absolutely a better way. There's absolutely a better way. I've never sat in a room with a decision maker who is struggling with what decision to make that wasn't absolutely laser focused on a better way. Better for the patients, better for the company. Yes, we have to run a profitable business. There's better value to be captured and shared throughout this system. I hope that resonates with everybody because I definitely have seen and listened to you share that with me. I hope now though that I'll be able to give you a little bit of a different perspective as well and why those resonate. What Arkell didn't share is I'm not just a sales and IT executive, a business leader, I'm also a patient. So I got diagnosed in 2001 when I got out of the Army with a heart condition. In 2014, I had a heart transplant at Cedars-Sinai in California. It's my second open heart surgery. I've had more than 50 invasive procedures that require anesthesia and informed consent where an adverse outcome that they tell you about to make you aware of is death. That's a pretty scary thing. I was discharged in 5 days, which was the fastest ever discharge from the world's largest transplant center. And it's not unique to me. My daughter has heart disease. My father had heart disease. He didn't have the same happy outcome that I had. And I have to tell you, the reason I share this with you is all of those concerns that I've seen leaders like yourselves struggle with, they all resonate with me. I've experienced every one of them, and I want to kind of talk about that just a little bit because I think it brings it alive. Reactive. When I first went into heart failure about 14 years ago, I was told I had pneumonia. I had multiple x-rays. I argued with the doctor in the emergency room. And I finally got to a hospital here locally, and the doctor said, did anybody step back and holistically look at your records? You know, you were gaining weight, you were vomiting, you were, not able to sleep. And I said, no. It took me 3 months of nearly dying before somebody was able to look at me and say, there's a problem here, and it nearly cost my life. Talking about inefficiency and waste in the system, now I want to talk a little bit about my dad. My dad had a transplant the year after me. Not the same institution as me, and I won't talk about the institution, but it was incredibly difficult for my family to watch what he went through. He passed away 33 days after his transplant. We had his records reviewed after the fact. We found he was on multiple, 3 or 4 different drugs that were competing with each other. He was being discharged from different floors, moved all around the hospital because there were rules and things that said, we got to clear the patient off the floor in a certain time or we get dinged or it makes our results and things look differently. That happens to be my father standing there in the right picture with me. Unnecessary tests, invasive tests. And that resonates with me as well because I've been on the table as well a couple of times. After you have a transplant, we're looking for rejection inside of the first year. That's the big thing. I'm 9 years out on July 4th of this year, and I've spent a lot of time in the cath lab. And in the cath lab, they either going through your groin or they go in through your neck, and they're looking, at least initially, they're doing what they call right heart biopsies to check the pressures in the heart, and they're looking for antibody-mediated rejection and cellular rejection. If anybody knows what that means, but they're basically looking at it in the blood and the tissue inside of your heart. it's an incredibly frightening thing when you go into a cath lab and they put you on the table and they gown you up. And if you've ever been at an operating table, it's like narrower than a diving board. It's not the most comfortable thing. And they're sitting there talking about you and they're not clear what's going on. And I'm like, hello, like, I'm here. I don't care where your date is tonight and I don't care what music's on. Like, this is the procedure. That's a really, really frightening thing. And it's real and it happens. It's happening now and it's happening today. The other part of it that I've definitely experienced, and this is really real, and the risk avoidance to me is incredibly, incredibly difficult to tolerate sometimes. You'll hear as a patient, new normal, new normal, new normal, new normal. It sounds like don't crash the car, but what it means is don't get your driver's license and don't ever get in the car. The new normal is great. You're just gonna have to learn to be what it is. You won't be able to run. You won't be able to jump out of an airplane. You won't be able to scuba dive. We have to lower your bed to the floor. We have to, all these things. The entire system as a patient that I went through is so risk and fear avoidant. Where I kind of like to take the presentation and sort of reframe that when we kind of talk about what opportunities that present going forward. I patently rejected all of that. It's just not how I roll. When I first got to the transplant center, I was walking laps in the hallway just to get some exercise. I wanted to, how do you pass the time when you're in a hospital? You have a PICC line, right, which is a central port they put in you so that they can draw blood out of you without having to stab you repeatedly. Well, I would walk laps around the hallway, and I figured 6 laps was a mile. So if I could walk 12 laps, I could walk 2 miles, and I'd do that 3 times a day. So I was trying to walk, 6 miles every day in the hospital. And at one point, one of the nurses stopped me and said, "You're walking too fast." And I was like, I'm walking too fast? Like, what does that mean? And she said, "Well, we don't want to get your blood pressure up." And I said, "Well, I don't really have a blood pressure right now. Tell you what, why don't you and I walk a lap together and we'll let them do an EKG on us and see who they want to talk to." And she said, "You need to go back to your room." And I was like, "Okay." And then I went and walked. And for me as a patient, I thought, I'm in a cardiac floor in a cardiac ICU with telemetry on, which means something, right? So it's like having Big Brother watching you because it beeps and alerts all the time and you can't go anyplace. And I have a nurse who's trying to get me to my new life telling me I can't do anything. And I'm like, what do you mean I can't do anything? You should never tell me to lower the bar, to lower the expectation. After my transplant, there's 2 types of ICUs. You have a regular ICU and then you have a step-down ICU. When you have a regular ICU, it's a one-to-one relationship with a doctor. You have dedicated nursing staff, and it's very intimate. It's the most critical time. It's immediately after surgery. Then you go into step-down, so that you have 2 patients to 1 doctor, maybe 3 patients to 1 doctor and a nursing team. Well, when I got to step-down where I was, after you've had anesthesia, they put you into a chair, and they have you getting out of bed, these basic tasks. This hospital where I was, they chose to seatbelt you into the chair. And I thought, can you explain to me why this is? And they said, well, you're a fall risk. And I said, well, look, here's the deal. If you can get the local collegiate physics department chair in here to prove that the laws of physics cease to apply, that my butt is lower than my knees, I'm not gonna fall up and out of the chair, I'll buy a seatbelt for everybody in here. But I'm just not putting a seatbelt on. It's subhuman. I mean, and I understand that there's a reason why you have to do that. That happens right now, here, today, and it's impacting patients. So what does this have to do with value? We talk all the time about quadruple aim. If you're not familiar with the quadruple aim, we talk about better access, better price point, better quality of care, and preventing physician burnout. That really, really resonates with me. I've experienced all of those things. But at the center of that is the patient. Everybody has to run a profitable business. I understand that. But it's the patient that the measure of value in terms of how was I treated? Did I get the outcome that I wanted? Would I do it again, obviously? Those are the important things. And so I've put up some ideas here, ideas that in prepping for this and doing some research, people like you, you've shared, these are not new items, and we can kind of talk about them, and I can explain to you why they would have driven a different type of experience for me. Maybe I'll just talk about one of them, and then I'll kind of bring it all together. The reactive nature of healthcare and the personalization and consumerization of it, that's a real thing. After I was transplanted, I got sent home and I was told all these things that I couldn't do. Don't eat this, make sure you sleep this much, make sure you drink this, don't ever do any of these things. And then I was sent home from the hospital. And doing some of my own research, I went out and found a closed-looped system that had a scale, a blood pressure cuff, an exercise monitor with some pulse oximetry. And I put that all together, and I started wearing it, and I started going to my doctor saying, hey, this is telling me I'm ahead of curve, I'm ahead of a curve, I'm ahead of curve. And I was able to not do cardiac rehab the second time because I was so far ahead. I went to my first cardiac rehab when I got back to Minnesota, and I showed it to the exercise physiologist and the cardiologist, and they're like, you do not need to be here. That's a real thing. But it didn't come from my doctor, it didn't come from the insurance company, but you can guarantee for me as a patient, it was valuable to me because I was able to take accountability for my life, which we know is highly correlated. Patients that are compliant lead to better outcomes. It's a real thing right now. I just read an article as I was prepping for this. If you're a Minnesota Vikings fan, you know who Justin Jefferson is. He was a wide receiver. He was at LSU. They won a national championship a couple of years ago. And there was an article that came out. How did everybody miss on Justin Jefferson? He should have been the first receiver taken in the draft. The kinesiologist, the team trainer of his own accord down at LSU, started asking him some questions about what makes peak athletes do things. Why are they better? And he was able to get 3 or 4 different companies, and over the course of 2 years, put together a profile of him that said he is the best at all of these different traits, his ability to process information at speed, the way he was able to react to certain things. They had proactively had a profile of this person. Now, he's an elite athlete, but they weren't bound by the convention of, I can't, I won't, I shouldn't. So for me, my stories are funny. There's definitely a rule breaker mentality that I have to me, a strong irreverence. I imagine that everybody in here, as a leader, you're rule breakers. You've gone against the grain. You've asked hard questions. You've said why not. You've pushed. I would encourage you to think about the art of the possible, and with that rule breaker mentality, what can we actually do? When I had my first open heart surgery, play a little spot the difference. Did anybody notice anything in that first picture that I shared? Anything unique about that? There's a spotlight in this thing, right? There it is. Can you see that little kidney bean on the front of me underneath my number? That's the controller for my LVAD, my left ventricular assist device. So if you don't know what that is, that's a heart pump. It supplements the pumping function of your heart. My first open heart surgery was 2 days after they told me I was going to die. They open you up, that hooks into the apex of your left ventricle, and then it siphons blood out, runs it through a pump, and then injects it into the aortic root. It supplements the pumping function of your heart. This was a bridge to transplant, because if you sprain your ankle, you get off of it for a couple of days, it gets healthy. When your heart gets sick, you can't do that. This was a heroic life-saving measure. They told me you'll never run again while you're waiting for transplant. I said, okay, we'll see. So I had this idea that I was gonna walk a 5K, and I figured I could walk a 5K and I could do it in 40 minutes, and then I'm like, well, maybe I can shuffle. If you shuffle like you know, your feet are theoretically, both feet are on the ground. That's walking, because when you're running, your feet are off the ground. So I'm like, okay, I can do it in 37 minutes. And it got faster and faster. And I said, well, the heck with this. I'm going to just go do the Minneapolis duathlon, which includes riding a bike. When you have a heart pump, you're also on a blood thinner, like Coumadin or heparin. So it was a 5K run, a 25K bike ride, and a 5K run. And in the middle of the race, I passed somebody, and they said, do you have an LVAD on? I was like, yeah, I do. I got to the end of the race, and who was waiting for me at the end of the race were two of my doctors that also did the race. Unbeknownst to me, I'd beat them, and the people that asked me about the LVAD were the perfusionist that worked in the operating room that gave me my LVAD. Now, if I'd listened to the rules and followed, I would have never done that. I'm not sure that I would do it again now, knowing what I know, because if I'd laid my bike down on the road going 25 miles an hour, I probably would have exsanguinated or bled out because I was on blood thinners. But I rejected the premise that I couldn't. I followed that up by writing the CEO of Thoratec, which was made that device, which was acquired by St. Jude, which was acquired by Abbott. And I said, you know, I kind of take issue with your mission. And this is sort of my parting shot here for you to consider. I said, it talks about giving me a life back. And I said, I don't want a life. I want my life. That's what's valuable to me. So as you spend the rest of the time today having some awesome conversations and talking about, to go back to John F. Kennedy, that things that are really hard, ask yourself, do I want to be a rule breaker? Do I want to go against the grain? And do I want to dispense with the convention? Why is it hard? Is it self-imposed? Because when we start to talk about value, and I can absolutely talk about, you know, accelerating prior authorization and, you know, clinical workflow scheduling, which are real opportunities for AI, the value of a patient is getting me my life back. Because I'll tell you, at the end of the day, I'm the real payer. I pay financially, emotionally, intellectually, spiritually, and physically. And so I would just encourage you to think about that. I wanted to give a few minutes here to see if there's any questions before I turn it back over.
Thank you. Peter, I don't know how often you have shared that story. I know that when we talked about it, it was something you had to contemplate. And I appreciate you sharing it with this audience. It was as compelling and emotional when I heard it this time as it was the first time. And I hope it was for all of you and really brings the point home. It's not about a life. It's about that person's life that you are taking care of. And we need to remember that every single day. So we have about 5 minutes for questions. And I want to remind everyone that there are people in the room that can give you a microphone. Please wait for that mic, because our guests that are participating virtually can only hear if you use a microphone. So I'm wondering if there are any questions in the room that anyone has.
And you can ask anything. I'm not afraid. So.
And I will, as we wait for questions, Peter will really answer anything. As we wait for some questions, my question to you, Peter, is if you could tie in your professional life and your personal experience, could you highlight an example, a specific one, where data would have made a difference in bringing you a better outcome, or where the data maybe didn't give you as good an outcome as you could have had?
Yes. So I look at, after I had my LVAD put in, I started gaining weight again. And I was told that this was something to look at. And I sort of dismissed the fact that I had some edema in my ankles, which is the swelling of your ankles. You know, you take your socks off, you have that line. Well, when you have edema, it gets pretty bad. I ignored that. I didn't do what was necessary. And I ended up having to go to the emergency room and having to go get some medicine, to take that weight off of me. I didn't have the data that I needed. There wasn't a system around me. It didn't equip me, didn't set me up to be successful.
And today we think a lot about, I mean, there are certainly remote monitoring technologies that are available to do that. And there were earlier technologies available even then, but we argue about who's going to pay for it. You know, who does the value accrue to, who's going to pay for it? And because we can't all figure it out, you didn't have it, right? And so we're not going to solve that problem here today, but it is an unfortunate conversation that we keep having that keeps delaying the care. So I have 150 questions I could ask, but I want you all to have the opportunity. Yes, right here on the right. Oh, yes. Why don't I give you one real quick?
Thanks so much for sharing your story. I'm also a patient, and I love seeing other people put themselves out there. I know how much it takes out of you to recount those stories and share those pictures. So thank you so much for sharing that.
Sure.
So I have sort of a reflection, I guess, with then a question.
Mm-hmm.
So talking about value, when you were talking about cardiac rehab, you knew you didn't need cardiac rehab, right? But you're like a highly educated person, right? You're a sophisticated consumer. I'm imagining, I don't know if this exists as a quality metric, but I know from like cardiac surgeons that, you know, follow-up with cardiac rehab is seen as like a high quality outcome. We want to promote that. And I'm wondering where you see the patient in these places where they might be tracking these quality outcomes and really want to push that on you to do it, yet you have the knowledge that you don't need it. You know, you're a particular type of patient. Where do you see kind of like the median healthcare consumer being able, you know, how do you see them being able to navigate that kind of like achieving high quality versus like what you know you need?
I think it's a great question, and I think it's an obvious gap in the system. To my earlier point that the system is reactive and it's predicated on patients entering into the system voluntarily, and yet doctors will tell you that every patient lies. I know, I lied to my doctor because I was so afraid, which is kind of diametrically opposed to, you know, the alignment and next steps. I found it interesting that there got a point in my journey that the doctor said, you have to go to other patients to get information, which again, I think is, you know, patients lie, patients have to opt into this system, but hey, we're super smart, but you got to go to other patients. That's true. I don't know how to solve that problem, but I know I spend and invest a ton of time with other patients. It gives me great value because I recognize that I'm lucky and I'm probably the exception being the rule breaker and owning that. But I love nothing more to spend time with other patients and talk and help advocate for them. You're actually seeing some institutions where they're having, you know, chief, you know, patient advocacy officers, because when you look at the makeup of a healthcare system, everybody's got an advocate or a sponsor except for the patient. And I think that that's a gap, and it's a complex one because it covers a lot of different sort of backgrounds and things. It's a great question. I just don't know that there's an easy answer other than for other patients who are so willing and able to serve and give of themselves to go meet other patients where they're at.
Thank you. We're out of time, except that I want to be thoughtful about our virtual audience. And Ed, I'm wondering if there are any questions that have come in online. And if not, then we can. Okay, well, thank you very much. Peter, thank you again. I can't wait to talk to you a little bit more later, and we really appreciate you sharing your story. And thank you for bringing Mary with you, his wonderful fiance that he's going to get married to soon. So, thank you.
Thank you.
Okay. Our next speaker is virtual, and I'd like to introduce Dr. Anand Shah, who's an emergency medicine physician and also the Vice President of Social Health at Kaiser Permanente. His focus is on standardizing the screening to look for social needs and systematically connecting people to services. But what really caught my attention when I was looking at Anand's background is that he is also focusing not only on the social determinants of health that we all think about, but also driving toward digital equity. Prior to his current role at Kaiser, Anand held appointments at Brown, University of Texas, University of Pennsylvania with the Robert Wood Johnson Foundation, where he also earned a master's degree in health policy and research. So with that, I'd like to transition to our next speaker, Dr. Anand Shah, on the value of data as it connects payers and providers to the community.
Well, good morning, everyone. Thank you. Thank you so much for having me. And it's just a pleasure to be with you all. And, you know, it's hard to follow such a moving testimony or experience that Peter just shared. And I'm going to pull up slides in just a moment. But I guess what I would say is I'm really excited for this conversation about how data can better inform what it is we do. And as I transition into some of the conversation, actually, I don't think I'm able to screen share. I don't know if someone can let me, or if you all can also pull up slides. But as we're doing that, you know, as I was listening to Peter, you know, and the sort of really human experience that happens every day for ourselves, our patients, our members, as a caregiver, the lack of coordination, the gaps that happen in our inability to provide that real value, it is a travesty, and that's what we owe it to ourselves. And part of what I want to sort of talk about today is one of the opportunities we have is to get a better picture of what's going on in each of our lives. And some of that happens in clinical encounters and biometric data, but there's also a lot of information in our communities, in different systems of record. And one of the things that we've been doing at Kaiser Permanente is thinking about how we can connect better to different parts of the ecosystem within which we all live. Let me try again, see if I can share. Oh, great. I think I can share now. Okay, let's see. Hopefully you all see my slides now. All right,
yep, we can see them just fine. Thank you, Dr. Shah.
Okay, great. Well, you know, where I'd like to start, you know, my name again is Anand Shah, and I have the privilege of serving as the Vice President of Social Health at KP. A little bit that I'll share for background about Kaiser Permanente, if you're not familiar with it, is it's an integrated health system. We cover 12.5 plus million lives across 8 states in the District of Columbia, have about 39 hospitals, 750 medical office buildings. And I share that to say, when you're part of a system like that, there's never a single approach to the work that you do, because healthcare is local, communities are local, and so there's always a balance in how you bring scale and work to serve the needs of all of your members, all of your communities in a consistent manner. We also are a not-for-profit that's been around for over 75 years, so the notion of existing within communities, as part of communities, is core to who we are as an organization. I want to start a little bit before I dive more into the work that I've been leading around social health and different support systems and connections to you know, also talking about how we exist within a broader health ecosystem in public health. And so, you know, I'd like to share a little bit about the notion of connecting to communities and different parts of the health system is really key. And actually, just last month, we convened different groups together to talk about opportunities for health systems, health plans, the public health system to come together with the American Medical Association, the American Hospital Association, the Alliance for Community Health Plans, the CDC Foundation, to really talk about 3 core things. How do we improve coordination between public health and healthcare? How do we improve partnerships between public health systems and community-based organizations? And what's the right kind of research agenda that would allow us to do this? And as we were starting this conversation, one of the sort of pieces that came up most commonly with our audience and speakers was actually the importance of the ability to share quality data, to do so in a way that, you know, maintains privacy and trust, but reduces some of the lag time, improves some of the granularity to start to answer those questions. Now, I will say, especially coming out of the last presentation, we must guard against ensuring that we understand that data is one input and is informative, but doesn't tell us the whole picture. But it is a critical step in our ability to sort of learn and move these conversations forward beyond what we gather through a claim or the fact that someone's had a clinical encounter or showed up in the emergency department, or that we have specific biometric readings about what's needed, or the amount of lab testing going on for, let's say, a new infectious disease that's happening. And as we've been thinking about this work, that connection to community-based organizations and other things was a driver of what brought me to KP about 4 years ago, in this role around social health. And what that role is really about how do we systematically identify, address, and provide support and follow-up to our members who have social needs. People talk about the notion of having social determinants of health, or that food or housing or other basic needs have an impact on well-being, is not new. It has face validity. And we actually have done very little across our country to think about how can we incorporate that into part of the story of care and the care experience and our members. When I came to KP 4 years ago, one of the first questions that I asked was, what do we know actually about the prevalence of social needs amongst KP members? And we didn't really have any clue. You might be surprised to find that KP by definition our members are by definition insured. Well, amongst our members, 63% in 2020 endorsed having a social risk in the past year. That's like inadequate or food insecurity, housing instability, trouble paying bills, lack of social connection. About half of them wanted assistance with those needs. Some portion wanted assistance from KP. And we also found, actually, to some of our surprise, that about 97% felt like it was important for this information to be included as part of their context, because they understood that for the individuals, for the families to get the care they needed, we needed to understand who they are and their preferences. And on some level, that's not surprising, but on the other level, that's very different than the way we've thought about these issues historically. You also will see at the bottom that, not surprisingly, there's different levels of risk and need, and we have racial and ethnic differences in the prevalence of needs. And it's disheartening and also, unfortunately, not that surprising. So what have we been doing to sort of address some of the risk and needs that we've been talking about? About 4 years, about 3.5 or 4 years ago, KP started on a agenda including building community networks. And what that really is we have a partnership with a third party called Unite Us, where we've partnered to think about how can we better understand which community-based organizations exist within our footprints. You might be surprised to know that there's 1.5 million not-for-profits in America. I think over 800,000 that support some kind of human and social services. So it's a huge number of organizations that do this work day in and day out. And very few health systems or plans actually fully understand the community. Our partnership with Unite Us was a step in the direction of better understanding that, building on relationships that we've had for decades in our communities based on community health work. So we've built out a resource directory that lists about 80,000 programs across our footprint, lists about 20,000 community-based organizations. And a portion of these organizations actually will receive referrals from Kaiser Permanente, make referrals to other community-based organizations, and share data across a closed-loop network with consent of the member or patient. And this was a way for us to start to fill in the white space of what's actually happening in our communities when people want to access food support, and are they able to get it? And one of the reasons that we made that investment was to better be able to invest our community dollars more effectively and to understand how we can advocate to fill in the gaps of community capacity. I'll just spend a moment here because I want to make sure we have time for slides. All of what I'm talking about can sound interesting at a high level, and it's a sort of broad systems view, but everyone is different, and we need to meet people where they are and have different modalities of support. And this slide is just meant to say that to do that, we've been doing screenings of social risk and needs, and that's been digital, in person, telephonic, via text, via telephone, via tablet, at a care encounter, at a health plan encounter. We're providing support through care teams, through a national call center, through our sort of online website, or doing direct outreach to help people enroll in SNAP or other public benefits. And part of this is to say, what we've found is different folks are responding to different channels. That's not surprising. And that might vary even across individuals. And really, I think the question for us is, how do we make that experience more cohesive for our members and ensure that that information is available to all members of our care team? I'll close with just, as we embark on this work, we've made huge progress, and we're at the very early days. I liken it some ways to thinking about neuroscience, right? We've learned a lot in the last 30 years, but we know very little about all the ways the brain works. And I think our ability to understand and partner between the health system and social services ecosystem is critical, but we're still very early. Some of the challenges are how you better align incentives in terms of finances for our community-based organizations, how we understand the heterogeneity of services that they provide and quality, how health systems like KP can be easier to work with and less onerous and not, share power. Can you imagine being a CBO with a staff of 5 having to partner with a legal department of 300 people? It's a little asymmetric. But the rationale is, members live in communities. We have a responsibility to meet people where they are, and understanding where gaps are actually has allowed us to target community investments more directly, and also to understand how to bring some of the data around gaps and resources to state level leaders, or in some cases, federal leaders, so that we can ensure, I think, a different approach. And so we're on this journey. We think that the ability in terms of how we learn will be the true testament of who succeeds in this space, and sort of cross-sector data is a key piece of that. Thank you for the opportunity to speak with you. I may have a few minutes for questions, but again, thanks for your time this morning.
Thank you. Thank you, Anand. And we absolutely have time for questions. I'll take the opportunity to start with one and then allow our audience to ask you their questions as well. Before you gave your presentation, my prepared question was going to be, how do you prioritize whether to focus on lack of housing, lack of transportation, food insecurity, and which one gives you the best ROI in your world? But after hearing your presentation, it was an aha moment for me to hear that you don't necessarily have to choose between those, and you've partnered with community networks. Would you say that that is a key strategy in being able to truly address social determinants of health, is partnering so that you can personalize and scale?
I would say that that's our take, that it's necessary and foundational to partner with networks of community organizations. They are the experts in the space. They've been doing it for decades and have inroads and trust with community members that we'll never be able to do. But I also think it's, it's also likely one of the challenges that we're also thinking about is, not each community is the same. And so what I would say is the place where we are is we've taken a fairly consistent approach across our communities based on health needs assessments to say, here are the top 4 or 5 types of needs that we need to support, and let's find organizations who can support them. And now let's use the data coming from our screenings and our referrals and our feedback from our community members and organizations to say, how do we actually rebalance that portfolio of the network and invest to ensure that it's tailored a little bit more effectively to that local community needs? But the short answer is yes, I feel that is a sort of a foundational element to this work.
Thank you. Questions from our audience?
Hi, good morning. Thanks for the comments and your vision around social care. I work at one of the 1.5 million nonprofits in the country. We serve older adults here in the Twin Cities, but we support a network that is statewide, and in other states we're building the infrastructure to begin to have the conversation with healthcare organizations like yours to really transform healthcare and social care and integrate them in the way you've discussed.
What's the name of your organization?
So I work for an organization called Trellis here in the Twin Cities, and we serve older adults. So my question is, I appreciate the explanation you gave about Unite Us, important first step technology solution that lets us give visibility to the nonprofits that exist. But like you mentioned the asymmetry around legal departments. Man, do I feel that. Like that's real, and it's also with the data. So my question is about data, right? You guys have data on your side. I don't have insight to it. So I have population health data. I don't have individual data that can talk to a patient experience like we heard about this morning, and that's where the value is. Where do we start having that kind of conversation about sharing data? We've got data on our side too, stuff you probably don't know. I live alone. I don't eat well. Do I eat? Yeah, I don't eat well. Right? Those kinds of data points that are so common in my world, but may not be as common in yours. How do we start having that conversation?
Yeah, it's a really important question. One, first, thank you for the important work that you do in the Twin Cities, and what I would say is it relates to data, or how I've been thinking about it, or where I see some optimism is I'm hearing a collective recognition of part of what you're describing, is to say, if we don't actually pool the data that we collect, and we can't just keep asking the same questions over and over again, we'll get different answers and create harm, frankly, for some of the most underserved and vulnerable members of our community. We're not going to see the whole picture. I would say KP is committed to finding safe ways to better share the data that we're finding in this space, because we don't see it as our data, or that we're trying to lock it away. And the reason I note optimism is I'm having these conversations with state leaders and federal leaders about how to find safe ways that conform to privacy and security rules to share that. And I've heard support from many of the different technology platforms that also work in this space. That's not a precise answer to your question in terms of here's the great solution that we've found, but I feel a lot of momentum, and many folks have at least identified the same problem. So I'm hoping we will make continued progress there. But I appreciate you naming one of the core issues that we're going to need to solve to bring value to our members.
Thank you. I hope we take some advice from Peter, who said we need to get over the fear-based barriers to the I can't, I won't, I don't know how. It's hard to try to figure that out, because it's essential that we need to connect our community network partners with all of the other providers that we have in our community to deliver the best care. Other questions from this audience? There's one in the back.
Yeah, so I'm working on a project that helps parents connect with the right resources in terms of community and guidance, similar to how you're connecting people. How do you ensure that the resources or the people that you connect with are credible and also relevant? Because information keeps changing. And how do you plan on to update it and vet the information before you give it to the stakeholders?
Yeah, another really important question. One of the challenges of being part of an ecosystem where funding is inconsistent is that changes the number of programs that exist and whether an organization can serve the same geography, et cetera. That's one of the reasons that we've had, partnered with Unite Us. There are other organizations that do this work to ensure that there is a consistent vetting of organizations that we bring onto the network and some regular updating of information. One of the benefits is that we were a few years into this project. Now we get also regular data around, hey, are we able to service needs on a 48-hour basis as we sort of expected? And if not, that's a signal to us that maybe something has changed. Is the eligibility inaccurate, or do we need to update the directory? So we have both sort of an upfront onboarding process through our partner and our community health staff that facilitates that, and then regular, both periodic upkeep and data that flows in. It's imperfect, but that's the way that we've been approaching the challenge that you described. I think ultimately that will get better with some of the standard data that came in the last question, and as we have better financial incentives to participate in the sort of collective support of our members and patients.
Thank you.
Thank you. Ed, any questions online? We have time for one more.
One question, Dr. Shah. You mentioned that you worked with within the network with a number of other stakeholders. Specifically, how did you incentivize CBOs to join this network?
Another critical question. I would say the way that we've grown our network has probably happened in a few ways. I would primarily say that the primary rationale for organizations to support, to join on probably comes down to a couple things. One, we're partnering with mission-based organizations who want to serve their communities. And if they see this as an opportunity to connect to other organizations and bring value, that there's some interest there. So that's, I think, one of the prerequisites. The second is we've had long-standing relationships in our communities where we've had done a number of community health grants and been an anchor institution. And those relationships, I think, were key in helping onboard community-based organizations. I think what's implicit in the question is, the platform is free for CBOs to use. What value do they receive in return? One is actually the sort of relaying back of aggregate reports, joint advocacy work at the sort of local or state level for resource gaps. A number of states, including California, are now actually testing models where we can use Medicaid dollars to pay for specific services. So I think that will be a different kind of financial incentive or relationship to support joining a network, but that's not how we started this work.
Great. Thank you so much. Thank you, Dr. Shah, for your comments. Really appreciate your participation. Let's give him a round of applause. Thank you. Okay, on to our next speaker, Dr. David Ingham, who is the Chief Information Officer for Allina Health, and he also maintains a small primary care internal medicine practice in Edina, Minnesota. And while I haven't been in practice for a long time, David, I would say that you probably get so much respect from your colleagues because you have to use the technology that you design and build, and that's so valuable and so important. So David is not only currently the CIO of Allina Health, but I was really impressed, David, that I found out that before you ever went into your professional training and graduate training, that you were a phlebotomist in the Allina system. So talk about really seeing how the entire organization works, and it gives you an appreciation for what needs to happen. Little bit of a tidbit on David. He not only understands what clinicians and providers need when he's thinking about the design of Allina's technology systems, but he also has a keen sense of what consumers need, because I found a clip of David being interviewed on Twin Cities Live on KSTP, my favorite station. And Twin Cities Live, if you've never seen it, is all about fun, food, and fashion. And he was so fun on this segment that when he was asked in, I think it was 2021, what he really appreciated and thought was great about telehealth, his first response, before his more professional response, was that he really appreciated getting care via telehealth, because he himself as a patient could have a visit wearing his Batman t-shirt and his fuzzy slippers. And that's exactly what patients want to be able to do when they're not feeling well. So thank you so much for that perspective. So with that, David, we'd love to hear your thoughts on the use of data in a health system.
Yeah, thank you. Thank you, Martha. Yeah, thank you for that welcome, and honor, privilege to be here with such a fine group. I still have those fuzzy slippers, but rumor has it my niece, for my next birthday, is looking for a pair of Anna and Elsa slippers, if you're familiar with Frozen, because she's really into it in first grade, and she thinks that I would like those too, but we'll see. Really appreciated Peter's comments around some of that experience you got and that you have in the hospital, and a lot of us have either been there, had loved ones, or at least heard about it and read about it. And I think you'll find that a lot of my information is trying to solve a lot of those problems. And really what gets me up every morning is trying to fix a lot of those problems he was describing. It wakes me up at night, and me and my teams, we're striving to improve those things. So I think you'll see a nice arc through some of that experience and then what we're trying to do. And spoiler alert, it's really hard and not easy stuff, but we're doing what we can. So I'm going to start first with a question for the group. And I'd pose, what would you say makes healthcare run? Money? Money's good. Disease, EMR. Maybe it's more what I think is at the core of healthcare, what we're trying to bring about through medicine and nursing. I would say, I think those money in that is probably too true sometimes, but people is really the core of healthcare. It's what we're trying to do, and specifically, I'd say human-to-human connection. Whenever you're a patient, whether you are in person in the hospital, whether you're on the phone, whether you're typing a message, we're trying to foster that human connection between the clinician, your nurse, the front desk person, whoever it is. And too often, usually I like to have a prop. If I have my computer with me, I'd use that, but pretend this is a laptop with lots of gigahertz and megabits. Too often the computer is in between us. The technology is getting in the way. And what we need to do is have that computer, all that technology off on the side, augmenting, supplementing. It's an incredibly important part, but it can't be in between us as it is far too often. But I will say we need lots of data too. So that's why we're here. We're going to talk about data in healthcare and how we can use that data, use this technology to supplement that human connection between patient and clinician. How much data does it take? I just say a lot, like a lot. In the history of humanity, you can go back a long way, and we had very little. We've essentially had no healthcare data until probably 1850s or so, when what they started doing in Paris is writing down the name of every person that came into the hospital. Pretty simple, not exactly what we do today. And you'll see today we're on the uprising curve of this hockey stick rise in healthcare data.
Worldwide, I was reading, they think 30% of all data generated is healthcare related. Tons and tons of data. I don't even really know what an exabyte is. I think it comes after petabyte, which is after terabyte, which is after gigabyte, but it's a lot, it's a ton. And just in my local health system, we have 12 hospitals, 100 clinics or so. We have about 400 terabytes of data, so a lot. And that includes our imaging, it includes our EMR. There's a whole source, and you can see these different, you probably can't see my pointer online, but all these different sources of data, whether it's the EHR, whether it's the payer, whether it's different patient information, genomic registries, and all of this comes together and creates this enormous, enormous set of data. But keep in mind, most of it is unstructured, meaning it's typed out. We can't just leverage it immediately. It's a huge barrier for understanding the whole person and what a person is about, what's important to them, and so forth. I like this cartoon because I think it does describe a lot of what we have in healthcare. We just want to grab as much data as possible, and we'll kind of figure out later what to do with it. We'll just put it all in a big data warehouse or data lake, or pick your favorite data source, and we'll figure it out. And what all that data, particularly the EHR, then promises is a lot. I just started typing off things that I think have probably been promised by big data and by the EHR over the last 15 years. And you may even notice at the bottom, peace and prosperity for all humanity. It's like, they go big. They go big. This will solve everything. What I would say is that although all that data, although the electronic medical record, all this tech has done a lot of stuff, it's really delivered some great capabilities, there's lots of new problems too. There are trade-offs. So when we can access records from all over the place, that sounds really great. We can get the records from out at Kaiser Permanente, everywhere. That is good, but then clinicians are expected to review all those records. They're expected to know all that data because we're afraid to miss something. We're afraid we'll get sued if we haven't reviewed every little thing. We have lots of really great pop-ups and alerts to help us provide safe, effective care, right? So if I'm in clinic and my patient's allergic to penicillin, I don't want to prescribe that, but I may have missed that in the sea of data. So we can have a pop-up that says, hey, Dave, there's an allergy to penicillin. Don't do that. That's helpful. Except when there's 100 of those types of pop-ups for things that are not important, not relevant to that patient, that also pop up. And it distracts people. It gets that doctor's head buried in the computer, and it distracts and disrupts that care. EHR, it's available at home, that's great. I'm on call, I can go in the computer and read stuff. It also means I have to read it. I feel obligated to go and do it, so there's a trade-off there. Patients were too far off, and too often our doctors, our nurses are buried in that computer. We have lots of data that we can send to regulators, insurers, so we can measure quality and so forth. But that has created an insatiable appetite from our regulators, our government, and others to have more and more data come in. And what that means is your doctors and nurses have to click, 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 put more data in. So there's a trade-off there. Then lastly, just to touch on, so if we have a big database, that's a pretty attractive target for some of the nefarious individuals in this world. A single health record on the dark web is worth, wait for it, $250. You know what the second most valuable record is? Credit card information, a person's credit card profile. That's worth $5, like nothing. So, there's this old quote about, why did you rob banks? That's where the money is. There's a lot of hackers and ransomware individuals trying to come after our data in healthcare, and that makes it difficult to make that data highly available for our clinicians in a way that's usable, et cetera. And I do want to comment just for a moment on data literacy. You can see this sea of data and one person's in there, jumping right in, it's okay. What I'd say is, unfortunately, a lot of our clinicians, our administrators, and others can't swim in data. We think we can, we want to. Either the water is too deep, the waves are too big, or too often in healthcare administration, we confuse correlation for causation We look at a connection and we think that's what's causing something, and we don't really dig into that root cause. Healthcare providers, again, we have so much data, you get distracted by it and you kind of lose focus on the human, the person that's in front of you, in that room with you. Tremendous problem. Now, before y'all think I'm a cynic and this is, you know, hopeless and all that, there are solutions. It comes back to having technology help us, be there to support, create synergy, and be there when we need it, but not get in the way. So I'm going to run through just a few solutions that my teams are working on right now and that I think provide some hope to come back to Arkel's bracelet, a little bit of hope in what the future can bring. So the first one is document summarization. At Allina, we have about 27,000 documents that are external, scanned in every day. Healthcare is probably the only industry in the world that still uses faxes as a preferred communication method. I don't know why. I'd love to get rid of it. It's impossible. But that means our docs have to review these things. Imagine pulling up a PDF with a crooked, fuzzy, 10-page typed out document. And they only have 20 minutes to see you, right? So what if the computer, using optical character recognition, using natural language processing, could read all those documents, and by the way, read the rest of all that unstructured data that we have collected the last 20 years and create a summary that's specific to you and your specialty and that patient. I'm working with a startup right now, really exciting stuff, where if I'm a cardiologist, I'm in the hospital, the application will know that. It will scour all the records, structured and unstructured, pull out what's important. When was their last angiogram? When was their first MI? What was their last EF? All these things that take time for a cardiologist to go and hunt and find. And put it in a way that's easy to read, meaningful, and summarizes really succinctly, and again, brings them back to focusing on the patient. They're not hunting and clicking to find this information. Next one, virtual scribes. I like to joke that our nurses are doctors. They're basically documentation specialists these days. They also happen to practice a little bit of medicine and nursing. I think never in the history of humanity have we developed something that we then need another human to help us operate. And that's kind of what happened with the electronic health record. Doctors are fumbling through, so what did we do? We got a scribe, a young, eager pre-med student who would come and do all the typing and all the clicking, and they're really fast, they're really good at this. That's ridiculous. We built a technology that we need another human to just operate? Come on. So what if we had a natural language processing engine and an AI engine listening to the visit in clinic or wherever, and then it wrote a draft note, summarized it. This would save our clinicians a ton of time, and again, bring them back to being able to focus on the patient, not worrying about typing and clicking and all this stuff in the visit. This is real. There's a couple of really exciting companies out there that we're partnering with to bring this to fruition, and I think it's going to be game-changing for our clinicians. I think, it'll take you back to the days before 1850 when the doctor came in and just talked to the patient, just listened, heard them, and understood what's going on. Instead of being focused on, is this pneumonia, because that's what one thing says. Instead, time to step back and see, you have swelling in your legs. This has been going on for a while. When you lay down, you get short of breath. Listen and talk to the patients. Really exciting. Autonomous monitoring. So, our nurses spend a lot of time taking vitals in the hospitals. Like if you've ever been in the hospital, they're coming in every so often, and it's constant. You got this cuff going off, you're wired up with your oxygen sensor, all this stuff. It's tremendous, it's a lot. What if we had a device that used, say, radar, and could actually take a person's blood pressure, take their heart rate, know how fast they're breathing, and do that continuously? Sounds kind of science fiction, like Dave, get your head out of Star Trek novels or something. It's real, it's being worked on, and it will, it has the potential to revolutionize how we care for patients in the hospital. This radar can go through gowns, it can go through blankets, it even can tell the patient from the doctor in the room. It can tell what the signal is based on how their skin moves and how they breathe and these different things. Creates a profile. Really fascinating stuff. And it not only would save time for our nurses not having to take these vitals constantly, we'd then have a continuous stream, so we'd be able to react quicker when there's a problem. And I'll get to later, we'd actually be able to combine that data with other sources of vital signs and be predictive, understand what is going to happen next so that we're not behind and trying to catch up. Here's a good one. So, doctors, especially radiologists and pathologists, expected to be perfect. And they're afraid not to be perfect. We have Dr. Ed, either radiologist or in training, I'm not sure, but he goes through they're terrified of missing something, okay? So many of you probably seen this or heard this monkey business illusion, where it's a video on YouTube, you can Google it or whatever. The task is to watch the ladies in the white shirts, how many times they pass the ball. And the video plays, they're kind of walking around, you get really intensely focused on counting those up. What happens is this person in a gorilla suit actually walks through the frame, and you don't notice that until afterwards when they show you. They're like, did you notice the gorilla walking through the frame? And you're like, I was blown away. I missed it. I totally missed it. I was so focused. I'm like, oh, I nailed the number of passes, though. But the corollary is when you have a patient with an acute condition, so say an acute blood clot in their lungs, or they have a broken bone, the radiologist, the other person, can get distracted from another incidental finding that's not going to kill them now, but maybe a cancer that's lurking that may cause a problem down the road. And so what if the computer could assist? It could see, oh, there's two things here. Dr. Ed, don't miss this other small thing that is not going to kill him today. It's not a problem right now, but could be a problem down the road. What if, when I was watching so intently, a big yellow arrow popped up on that gorilla so that I saw something really important coming through? This is increasingly prevalent, really exciting time. I will comment, Ed doesn't need to worry about his job. I don't think this is going to replace radiologists. I don't think it's going to replace doctors in general. I think it's going to assist, it's going to help them, because there still needs to be clinical judgment. There needs to be understanding who this patient is, what the context of the findings are, things of this nature. Computer can't do that. I don't think, at least in my lifetime, it will be able to. In basket. So you all have an email thing, and it gets loaded up every day. Mine's like Pottery Barn and whatever emails I don't care about that my wife signed me up to get coupons. So imagine that like times 15. You have not only emails coming in from like outside hospitals and whatnot, but you have messages coming from patients, you have results from labs coming in, you have copied things from all those faxes that came in, all kinds of stuff. And you're supposed to deal with this throughout the day while you're trying to see patients and while you're trying to not miss stuff and trying to be perfect and all this. You can see this graph here. Medical messages through the pandemic blew up, skyrocketed. It's crazy. This in-basket burden is destroying our clinicians, our primary care docs and nurses. They're overwhelmed with it. So every message that comes in, a medical assistant from a patient, medical assistant has to read that and then kind of triage it. So if it's a refill request, they route it to the refill hub. If it's a question about a medication, they route it to the doctor. If it's, I'm having chest pain and I can't breathe, you know, they call the patient right away. There's this sort of stuff, right? What if the computer could read and then an AI engine routed those messages? That is real. We are working on it right now. And then to take it the next step, which is aspirational for me right now, but I want to get there, what if it could reply back when appropriate? If you're asking, was I supposed to take 1 pill or 2 pill? I forget what you said, doc. It could read the note and say, you're supposed to take 1 pill. And you don't even need to bother that medical assistant, bother that doctor with this simple question. This stuff is becoming very real. We are in a proof of concept right now for an AI engine to route and manage these messages so that our nurses don't have to read them all and so that they get to the right place in a timely manner and so forth. Really exciting stuff. I'm almost done. So when Peter was in that ICU, There's a ton of equipment, and he talked about some of the beeping and the noises and all this stuff. And there's a lot going on there, a lot of information, a lot of data, and it all goes different places. There's no like cohesiveness to it. The cohesiveness is the nurse and the doctor looking at it and making sense of it, okay? And Peter talked about breaking rules, thinking big, going beyond what's normal. So right now, Allina Health, we're building a $1.5 billion hospital tower down at Abbott Northwestern in South Minneapolis. It's supposed to be state-of-the-art, like top-notch technology. I am in charge of all that technology, so I'm a little nervous. But my challenge to the team was, what would it take to give a patient a full night's sleep? And if you have visited in the hospital, especially in the evening, exactly, yeah, it's bad. There's IV pumps going off, there's this and that, and a lot of it is important. Like, we actually want the nurse to know if your blood pressure's down, this sort of stuff, but a lot of it is nonsense. The bag ran out and the IV pump is beeping to the patient who's trying to sleep instead of beeping to the nurse down the hall who actually could go get a new bag to fill it, right? So what we need is what I describe as event-driven architecture. We need an engine, an algorithm that can take in this information, be proactive about it, be predictive, weed out the stuff that doesn't matter. So Peter coughed, we don't need to alert the nurse or whoever about it, right? But if Peter's O2 sats are dropping and his blood pressure is low and he's breathing fast, I want the computer to immediately alert a bunch of people. Like, that's important. We want to know about that. We want to know right now. And so the ideal state, what I'm driving for, I'm hoping for, is to have all that data come in one place, runs through these algorithms, AI engine puts out the appropriate alert to the appropriate person at the appropriate time. So if, so really, really difficult stuff. This is somewhat, I believe we'll get to some of this in this new tower. I don't think it's going to be perfect. There are rules and regulations, and turns out it's really hard to change congressional law. So I'm learning. So IV pumps, there's actually a federal regulation that's based on a law that says it has to beep at the site, like at the actual pump, as soon as it detects a problem. I'm like, it's the wrong person, the wrong place, the wrong time. And so these are some of the challenges that make it difficult. But again, sticking with that bracelet and hope, I'm hopeful that we can get there. And it's all about keeping that clinician, that caregiver focused on the patient, keeping the technology on the side, helping, supporting, and making that as great of an experience as possible. So thank you. Oh, I have a summary. People are the point. Data brings benefits, but trade-offs. Solutions can assist, but not replace us. So.
Thank you so much. I want to keep us on track, so we're going to defer questions, but if you are going to be here during the break, maybe people can ask you there. But I will end and transition us to break with two comments. One is, you're such an awesome speaker and, of course, a great CIO, but if you ever need another job, I'll bet you could be the anchor on Twin Cities Live because you got it down. You're so good. And the other thing is that if you accomplish giving patients a good night's sleep and not interrupting them, you truly are even more of a superhero than Batman.
Good one.
Thank you very much. We're going to go to a break right now, 11:45. Please come back. 10:45. Please come back at 11, and we'll get started with our next panel.